Welcome to the UNCG Entry-Level Masters in Athletic Training Education Program Preceptor Initial Training. These are our video modules. Want to first thank you so much for agreeing to be a preceptor. I've said for years that the strength of our program really does lie in our preceptors and the people we have affiliated with our program. So thank you very much for agreeing to be a preceptor, and I hope you enjoy these video modules. We have 4 modules for you. At the end of the 4th one, there's going to be a link to an online quiz that you have to take to verify that you've completed the training. And we'll also schedule a one-on-one face-to-face meeting to go over any last-minute questions or concerns, etc. that you might have. So let's get going with the first module. And the first module is Introduction to Athletic Training Education, where we're going to talk about education and athletic training at the national level, and then hopefully narrow it down to what we do and how we work here at UNCG. Now, the first thing you want to realize is that we have 2 main bodies which govern us. Obviously, the first one being the NATA, and the second one being the CATE, which is the Commission on Accreditation of Athletic Training Education. And these 2 bodies have put together 2 main documents, the 5th edition of the Competencies and the 12th edition of the CATE Standards. Now, the Competencies is what goes into the educational component, saying that this is what entry-level athletic trainers graduating from a program need to be knowledgeable in, tested in, assessed in, etc. And you're going to notice in a couple of slides I'm going to show you that the 5th edition of the competencies are going to be probably pretty different than the competencies that you graduated from. And that's okay. It's just the evolution of the athletic training education. And the CATE standards, that's what we need to run the program and to remain accredited by CATE. And obviously, if our program is not accredited, then our students can't sit for the BOC. So we have to abide by the CATE. So if you ever have any questions, why are the students learning this, or why are you doing this, a lot of times those answers can simply be they have to because they're in the competencies, or we have to because it's part of our standards. The way athletic training education today is, and how we run it here at UNCG, is that they're going to get formal instruction in the classroom and in the laboratory. That's where the faculty and staff come in. So we give them that didactic knowledge. We give them all the information in the classroom and the laboratory setting. And then they're supposed to take that and put that into clinical education, which is where you as the preceptor comes in. You are taking those clinical experiences to provide them opportunities to take all that didactic knowledge and put it into real patients in real time on real injuries. And what we want to see is that there's a seamless interaction between the 2. And that's what we are seeing. A lot of our preceptors, and all of our preceptors actually, are buying into that, and they really do a great job of taking what we use in the classroom, building it into their own clinical practice, and really developing fully functioning clinicians. That's where we are right now in athletic training education. I mentioned earlier that some of the competencies might be different. This is copied from the 5th edition, and we have now 8 content areas, and there's been some wordsmithing, etc. What you're going to notice is something like the acute care content area, which is right here. These are things that students graduating from programs need to be knowledgeable and assessed in now. And some of these you might never have had to deal with before. I never had to take a rectal temperature when I was in school, but now that's the gold standard for taking core temperature. So all students graduating have to be assessed in rectal temperature. You're also going to notice something down here where they use verbiage very differently. So AC9 is acute care 9, AC10 is acute care 10, so it's the acute care content area. And you're going to notice that I put in italics these 2 words, differentiate versus establish and maintain. And that's very important because differentiate the types of airway adjuncts can be done in many, many different ways. You can just write a multiple choice question, and then you can say that the student is able to differentiate them. Whereas something like establish and maintain, that implies that there's a psychomotor component to it, that the student is actually physically doing and using an OPA and an MPA. So even though it might seem like minute little differences, they're very, very important when it comes to how we assess and how we put this content and these competencies into our overall program. And then the last bullet point right down here, this is really, really important, that the first responder, first aider policy is no longer in play. Okay, we cannot do that anymore. When I was a student, here's your radio, here's your kit, go out to practice, I'll be inside if you need me. We can't do that anymore. We can't leave a student unsupervised at practice. We can't send them on the road by themselves. We just can't do any of that. It puts the student, it puts the patients, it puts everybody in a tremendous amount of liability. And honestly, in terms of the profession as a whole, it downgrades the profession, because what it tells people is that a non-certified student can do the role of a certified medical professional, and we don't want that perception out there. Okay, our students are students. They're there to learn. They are not there to replace full-time staff. All right. So the next few slides, when we talk about program delivery, this is all copied and pasted directly from the CATIE program. And this is what the CATIE standards say that we need to do when we are delivering our program. And the second bullet point, this one right here, is where we really do the best job, that we provide our students with authentic, real-time opportunities. We don't do a lot of simulations. We really try to make sure all our students are getting real patients, real time, real injuries, etc. Alright, and you're going to notice down here that we give our students a variety of different opportunities of different populations, care providers, etc. So they have different sports, different teams, different levels, etc. So this is how CATIE is saying that we have to deliver our program, and I think we're doing a really good job on these points. And you look at continuing to how we need to deliver it, that CATIE wants clinical experiences, including but not limited to individual, team sports, what we call the number 2, the sports requiring protective equipment. We call that equipment intensive, male versus female. We have our students to emergency room, etc. So you can see that the CATIE is telling us we need to give the students variety, and when we get to our plan of what we do at UNCG, we're actually delivering that pretty well. Moving on, when you look at the evaluations, we do evaluations of all our sites and all our preceptors routinely. Letter K is different. It used to be an athletic trainer had to be the supervisor of all the clinical experiences, but now they changed the wording to the majority. So if we have a PA or a PT or a doctor or somebody who is in the appropriate credentialed medical or allied healthcare, they can watch over your students and they can actually assess and act as a preceptor for our students. So that's just trying to show that athletic trainers can work seamlessly with other medical providers, which I think is really, really great. You're going to notice that if you look at letter L, number 1, this is very important, that we give them instruction on the skills in the classroom first. They have to have that formal training first before they can go out into the clinical setting. So we are not expecting, and we cannot hold a student accountable for, let's say, a knee evaluation if they've never been taught how to do a knee evaluation. Now you can show them, you can teach them, you can walk them through it, but you can't hold them accountable for that information if they haven't had the formal instruction first. This is our last slide on program delivery, and it's just going over some of the more nuts and bolts things. So when you ask why does this have to happen, there has to be a written policy for minimum and maximum hours. We have a minimum of 300 hours, which is a 15-week semester or rotation. So it's about 20 hours per week, because 20 times 15 weeks is about 300 hours, and they have a ceiling of 500 hours. So we don't want them in their clinical rotations longer than 500 hours. And they have to have at least 1 day off every 7-day period. Remember, they are not part of the full-time staff, so they don't have to be in, and they cannot be in there 7 days a week working 12 hours a day. They are students first, trying to build on their clinical experiences. And that's, they say this again down here in number 4. We do a lot of communication between myself as clinical coordinator and the preceptors. This is going to happen formally, informally, emails, text messages, etc. So I try to stay in as much contact as I can. And please, if you have comments for me, send them right back to me, because I'd love to hear the feedback from our preceptors and see what's going on. And number N, letter N, number 3, this is the big part again, where it directly says students must be directly supervised, and the preceptor has to be able to intervene on behalf of the student and the patient. So what this means is, let's say you are working a football game or a football practice. You don't have to be right next to the student. You can be over on the other side of 50, but if the student is doing something, or if they go onto the field, you need to be able to get out there and intervene on behalf of the patient. So you can't be in the athletic training room. You can't be around the corner doing something else. You have to be able to see what's going on and intervene on behalf of the patient and the student. And obviously, patient protection is the big one there, okay? Now moving over, this is UNCG in a nutshell. You can read about what we do, but we have We have the most unique setup, I think, because we're an entry-level master's. We get older students, we get students from varied backgrounds, we get business majors, anthropology majors, exercise science majors, etc. So we have a really, really diverse pool of students. They are highly motivated because they want to do this. They're going back for their graduate degree for this one reason: they want to be athletic trainers. So we can really push them, and we can expect a lot out of our students. Looking about the faculty that we have here, Dr. Scott Ross, he's our program director. He's in his second year, and you can see where he's coming from. He's coming over from VCU, where he was program director and clinical coordinator there. This is me. I'm Aaron Terranova. I'm the clinical education coordinator. It's my 5th year as faculty at UNCG, but I've been here for 8 years. And I am coming from the Merchant Marine Academy. And my job is really to oversee all of this clinical experiences for the students, to put them into clinical rotations, to answer any questions you might have. Randy Schmitz is one of our other faculty members. He's been here for 15 years. He sort of started the UNCG program. He started our athletic training program many years ago, and he's obviously full-time faculty. And Dr. Sandra Schultz, her and Randy are big in the ACL research. They run our Applied Neuromechanics Research Laboratory, but they're also our faculty. So these are the 4 main faculty who will be giving them the formal instruction, as well as other adjunct faculty we have here at UNCG. In addition to the full-time staff at UNCG, we have doctoral students, we have off-campus ATs, and that'd be you as preceptors, we have grad students, etc. So we have a wide variety of experiences, a wide variety of knowledge, a wide variety of backgrounds that we expose our students to. So that's the end of the first module. I hope that gives you a brief overview of athletic training overall. I hope to give you an overview of where we've come as a profession. And now we will look forward to moving to module 2 and go from there. So please click on the second video, which is module 2.